Welcome to WADM's webinar on information management and decision-making regarding personnel during the COVID-19 outbreak in Israel with Dr. Shoshi Goldberg. Thank you for taking the time to join us today. I'm Sarah Vega, the Program Assistant for WADM, and I'd like to cover some logistics before we get started. During the webinar, feel free to submit questions to the presenter via the question tab located in your control panel, and we will share your questions during the Q&A session. During the Q&A portion, you may also use the hand raise function on your GoToWebinar control panel to verbally ask your question. In addition, we will make today's materials available to you, and we will send you an email to let you know when the recording and the slide decks are ready. And that's about all I have. I'd like to give the floor to Udeta Benin-Goren, the chair of the WADM Nursing Special Interest Group, who will introduce Dr. Shoshi Goldberg.
Hello, good afternoon from Israel. Welcome to the webinar of WADM. I would like to introduce Dr. Shoshi Goldberg. She is a registered nurse holding a master's degree in health system administration and an honor PhD in administration. Dr. Goldberg is a director of nursing division and national head nurse of the Israeli Ministry of Health. In her position, she has led many reforms in the health system and has been working to empower and promote the profession of nursing in Israel. Her activity has been centered on the academization of the profession, the service orientation, the empathy, the compassion, quality and safety of the care, as well as developing the backbone of nursing leadership. Dr. Goldberg promoting the nursing profession, including the development of an advanced courses for nurses, which include new role of nurses. She also determining the nursing central work, the nurses domain of authority and responsibility, management, and the entire of the license area, development and professional guidelines, and the work requires standard regulation and legislation. The central vocation motivating Dr. Goldberg is a vision and faith in nursing unique and important contribution in advanced optimal care for the population. During the COVID-19 crisis, Dr. Goldberg took upon herself the responsibility and the management of the entire workforce in the health system, and she will present the job and the challenge in facing this work during that time. Shoshi, Dr. Goldberg, the stage is yours, please.
Thank you very much. Hello, everybody, and thank you, Andrew and Sarah and all the participants for the opportunity to share with you the experience coping with COVID-19 at Israel. I also would like to thank Dr. Rama Zilber and Dr. Udeta Benin-Goren for the help on preparing this presentation. This is the current morbidity picture in Israel. We have 9 million people in the country, 20,000 were sick, 114 were ventilated, and 300 died, including one nurse. As we look at the morbidity picture of the staff, we can see the peak of absent staff at March and April. You can see it here. We are coping with the COVID-19 during the period between January till now. We can see the wave of morbidity and similar to it, the wave of staff absence, and at the same time, the manpower immediate assistance that we gave with more than 7,000 health workers at the peak of the disease. The strategy of the Ministry of Health included 4 main steps. The first one was prevention, the second one was containment, the third one was calming, and the last one was preparing for the second wave. The preventing period main purpose was to postpone the arrival of the first patient as possible, just to earn some time as we could. The main actions were professional guidelines such as diagnostic measures of suspected COVID positive, legalization and regulation aspects like closing the sky to flights from China at the beginning, announcement of COVID-19 as epidemic, moving to remote medicine and using medical technology, especially monitoring devices and sensors, regulating therapeutic Zoom meetings and medical consultants. We also changed the work hours to shifts of 12 hours per staff. We tried to raise financial and manpower resources. We opened a corona department and added more beds to the general hospitals. We had 600 new positions for nurses and 200 for doctors. We started to buy as much as we could, ventilators, reagents, swabs, gloves, medication, and also started to produce all those elements in our country. With a massive communication and staff education, 3 main messages in all languages, and with public opinion makers delivery to the public by all means of media, putting masks, washing hands, and keeping social distancing. The containment started at the 25th of February, as you can see here. This was the first patient that discovered at Israel. And from this point, the main purpose was flattening the curve. Many very dramatic actions were taking place directly by the Prime Minister and the Minister of Health of the country. Actions such as sky-full closure, closing schools and universities, full quarantine to the citizens all over the country, stopping elective procedures at hospitals, giving Magen David Adom, the first aid organization in Israel, the responsibility of taking the swabs, first at homes and later at drive-through allocations. Opening Corona Unique National Control Center, the Ministry of Health, together with special technology departments from the Army and the Israeli National Security Systems. And we, the Nursing Division, opened the Workforce Department. We had a lot of challenges. We had to work quickly in uncertain situation, learning while running, making a lot of mistakes and trying to fix them, taking decisions at real time on the spot. We made daily reports of healthcare workers' absence and the impact on the functioning of the system. We recruit thousands of new health workers. We trained the new staff. We prepared for the first time using legal orders to place workers if and when needed, and we gave support and recognition to the health workers. We developed national data system. We gathered daily information from more than 100 health institutions. We sent more than 35 daily reports to all participants, from the Prime Minister to the organizational leaders. We showed the results, we compared between them and between the country results, and we shared between them the insights and the action that were taken in order to improve the system all the time. Here you can see some of the examples of those reports. A daily report of healthcare worker infection rates. Another one is a daily report of quarantined personnel according to the work institutions. And the last example is a daily report on personal infection status. At the recruitment phase and allocation, we worked according to a scenario of 5,000 ventilated patients and 10,000 very sick patients. We had 26,000 of new personnel that identified as backup to the system. We gave 800 temporary licenses to nursing graduates without giving them the opportunity to be licensed. And we had a legal directive placing medical staff from the private hospitals when we stopped their activity in allocated posts at corona departments. Here you can see the trigger. You can see that we had very few ICU and anesthetists, more personnel teams that came from the general wards, and the large amount of assistance that came from untrained workforce, especially medical students and nursing students. More than 7,000 health workers were placed, and at the peak time of the disease on March, more than 3,000 of them were employed immediately, as you can see it here. We also updated the knowledge and the skills and the qualification of the staff. We started with expanding the authority. Nurses that work in corona departments had an independent authority in several actions. Phlebotomists had the ability to take blood at home, and paramedics that usually work on ambulance had the opportunity to work in the corona departments. We had a formal training regulating the educational standards and developing a distant learning modules. All of this was made by the ministry. And the other one, and the third one was on-site skill training. The staff was trained as organic team at the workplace in real time. This was made by the organizations themselves. We also made a lot of actions to maintain the workers' well-being, such as open hotlines, open schools and daycares for health workers, children, and proactive communication with corona sick health workers. More than 300 phone calls raised problems such as need for emergency dental care, need for gynecological follow-up, need for grocery supplies, care for family members, support for social welfare, and so on. We also find the time to celebrate the Nurses International Day. We made a lot of rounds and visits to the field, meeting with all levels of staff. We had daily Zoom with the general manager and the ministry managerial team, and also with the headquarters of the community departments and the hospitals. We published health worker stories and photos. We got a lot of public appreciation and solidarity, and also we were very excited when the Israeli Air Force had a flyover the sky in the Independent Israeli Day. The curbing stage came in May when we had only several patients per day. The government established a roadmap for the return to routine. Schools, restaurants, public transformation were back to work. The Ministry of Health established Prime Minister dashboard defining criterions for the second outbreak of the pandemic. The criterions were a daily increase in case number double within a 10-day period at minimum, over more than 100 new cases per day, and over 215 cases of several patients. At the middle of June, soon after the schools were open, we started a new corona wave. This morning, we have almost 500 new patients per day. This scenario meet us again, maybe more prepared, but still don't know everything about the coronavirus and learning by walking or really by running. Thank you very much for your attention. Maybe someone have a question?
Thank you, Dr. Goldberg, for the presentation. So we are now at the point of the webinar where we can take questions from the remote audience. You can either send those in and I will read them out loud, or we have the functionality to unmute your microphone and you can ask a question directly.
I would like you to ask the question and then I will answer. I don't want to touch the dashboard now. Is it okay, Andrew?
Yep, that's
okay.
I have a question for you.
Okay.
In presentation, you had mentioned there were 26,784 backup staff personnel. Were those all people who previously had medical or nursing training?
Okay, I can answer it. So we had several levels of manpower backup that we had. First of all, we tried to find out all those physicians and nurses that didn't work at this time, at that period. And after calling them, it was almost 1,000 of them that was between jobs or worked, part-time, and they wanted to take part in the corona department. So first of all, we recruit them. And then we stopped all the educational programs that we have. We have a post-basic courses in a lot of aspects, and then we stopped them, mainly the critical care courses, and we bring back all the stuff to the departments. And after that, we went to the students. First of all, we asked them to volunteer. We asked the medical students in the clinical years to come and help, and the nursing students. And even for the first time in the country, we prepared legal, some kind of a legal option that if they won't come to volunteer, we can give them some kind of an order and put them at the corona placement. We didn't need to use it because we had a lot of, a lot of volunteers. At the end, we succeeded to have 26,000 persons as backup. And we sent only 7,000 to the field, and they immediately got 3,000 of them. First of all, those were more qualified. Another thing that we did was to have the option to take all the private staff from the private hospitals. Then we have a lot of anesthesists, post-basic acute care nurses that could come immediately if you close the private hospitals to work in the public hospitals. We have those lists, but we didn't still have to use them. I hope I answered your question, Andrew.
Yes, thank you. I have another question for you. And please, those in the remote audience, if you'd like to ask a question, feel free to submit a question and I will read it out loud. But I have a question. You had mentioned that approximately 1,000 medical personnel in Israel became infected with COVID-19. Where did most of those personnel quarantine? Would they just do that at their homes, their private residence, or did the government provide a location for medical personnel who were infected to quarantine? How was that handled?
Okay, it's a very good question. Most of them at the beginning, it changed during the time. At the beginning, most of them came from abroad. You know that, and most of them were physicians, doctors. You know that they are used to go to a lot of conference and meeting abroad, and then when they come, and then when they came, they were sick. This was one group. When the time passed, there were a lot of staff members that got the coronavirus from social meetings in the departments, like eating together, traveling together, have parties together. So they just influence one another till we stopped it. We understand it, we shared it, and we stopped it all over the country. And a lot of them outside the hospital or the community services, like everybody else. We don't have a special quarantine for them. Only one of the biggest hospital in the country that has hotel inside him gave their staff the opportunity to stay there in a quarantine, but they could use an hotel. The government gave to all the citizens the option of using hotels or stay at home. Odeda, she was the person who make all the telephone. Maybe she can say something about it. Odeda, you can hear us? We cannot hear you.
Okay,
So
now, yeah. Sarah,
now,
okay.
yes.
Yeah. Okay, well, let me tell you, most of the people were either hospitalized in home or in the hotels. And the Israeli health system developed a very organized system for home hospitalization, including follow-up by nurses from the community. And those who were minor patients, who didn't require an intensive care unit, which were the most of them stay at home unless they couldn't manage at home being quarantined over there. So they have the opportunity to be in hotels that provided, like Shoshi said, by the government. The major issue were related, like she said, to the support of the welfare of the people more than the health problem. Although we did have some patient staff that deteriorate during the time. So like Shoshi mentioned before, we had one critical nurse that passed away after about 3 or 4 weeks that she was intubated and ventilated. And it was quite a very sad situation for her, but also to the whole community, because it's quite a small country and people are very much involved with each other and know each other. And we have another doctor assistant that was critical patient and was connected to ECMO, and some others that the condition deteriorated, so they refer from home to the hotel and then from the hotel to the hospital. But this was the majority of the staff who got sick were mostly minor patient and not require really a very hard intervention. This additionally to what Shoshi didn't say, to those who've been in quarantine because they've been in touch with patient, but they were not sick. So
Yes.
Shoshi may add to this because they are missing a lot of personnel in the system. This is one of the gaps you need to overcome when she had to refer more personnel, because I think we have about 3,000 personnel that were quarantined, and not because they were sick, but just for the quarantine period, right?
Yes, you can see it in the graph that I put now.
So
Those 3,000 of people were in quarantine because they met some kind that was positive, some person that was COVID-19 positive.
and this obviously create a huge burden on the system, because we need to find their place, and this is what the headquarters, the personal headquarters did during the time.
Thank you, Dana. Another question?
We have a question from the remote audience. It's a kind of a two-part question here. First, it says, how were the hospitals organized? But that leads into the second part of the question. And it says, how was the urgent medical help organized for patients with acute myocardial infarction with unknown COVID status?
Especially to this group, focusing only on this group. Can you please go over the question again, Andrew?
Sure. Well, I think what's being asked is, how did you handle non-COVID medical conditions? Like, for example, when a patient came in with an acute myocardial infarction and it wasn't clear whether the person was infected with coronavirus or not, how was that handled?
So as I've said before, we learn during the situation. We didn't have all the answers. Even now, we don't have all the answers. So I can answer this question in several aspects. First of all, a lot of people didn't came to the hospitals. They stayed at home, and they used the services in the community. And we were talking about it a lot, and we were really afraid that people who need treatment, immediate treatment, will not come to the hospitals. So we had several communication, media communication and explanation to the public that there is another way, another round, another path that they can come to the hospitals without involving the COVID-19 patients. There was a period of time that we didn't separate between the patient because we didn't know who is with COVID and who is without. And then the system, it improved herself by the time. And we had different emergency pathway for people who knew or was suspected to be COVID-19 patients. We even had, some kind of devices that hospitals developed that you don't have to be in a contact, in straight contact with the patient, and you can stand behind some kind of a mirror and then take the swab. And many of the hospitals had a department that the patient could stay there until they got the answer of the swab and decide if they are coronavirus or not. Many times, I can tell you, we didn't find a time that the person was with COVID, and all the teams went out to their homes. Just in the last week, we had to close one of the biggest internal department and one of the biggest hospitals because a patient came and they didn't know he had COVID, and still in that time, all the staff went home, and the department was closed. So you try to understand and put rules, but you don't always succeed.
Thank you for that. If anyone from the audience would like to ask a question, please feel free to send it in, and I will read it out loud. I have another question for you. Oh, we did get a response that thank you for answering the question from the participant who submitted that. You had mentioned towards the end of the presentation that Israel might now be experiencing a second wave, and that there are nearly 500 new infections per day. Was my understanding of that correct?
Yes. Yes, this is what happened now. When we opened, in May, we started to feel that the coronavirus is very silent. So the government decided to open all the services. People were, were in a very bad condition. They didn't work for a lot of time. They wanted to go back to their lives, and they opened the schools, and it didn't take a lot of time. And then we started to see more and more patients. We had more and more examinations. We are doing a lot of examinations now, more than 13,000 examinations per day. So we find more patients. And we try to, to break the epidemic system or lines. And we are now in a new situation with 500 new patients per day. And we still have the national team that works, and they have the dashboard for the Prime Minister to see what happens every day. Yesterday they closed several places. We are using a lot of, public education and messages that we bring back to the citizen to keep their mask to keep the mask and the hand washing, and to keep the distancing between people. And we try to do whatever we know to do till now to stop this new wave that we have. You know that in 2 weeks, when we started it, we can see only this morning 100 staff persons that are in quarantine, and almost 200 that are sick with COVID. So we see that we are starting this wave again, and we are climbing again, and we hope to stop it before it will be a catastrophe. Thank you, Andrew.
Yeah, thank you for answering that. I think that's going to be a big challenge for every country that's starting to relax restrictions to some extent and try to reopen economies and societies. There's here in the United States, for example, there's several new hotspots emerging that tend to be places that opened up earlier than others that didn't experience an initial wave of infections and hospitalizations. You probably had seen on the news that New York City was hit particularly hard. And now New York City is actually doing reasonably well with new cases and much lower rates of hospitalizations. And now there's other epicenters forming in the United States. And I feel like this will be sort of an ongoing situation we'll find ourselves in for several months or longer, with new cases and new hotspots emerging as economies open up regionally and globally. But I don't have any more questions from the remote audience, and if there really aren't any other questions, we might be at a point where we can wrap up the presentation and the discussion and finish things for the day here. Did you have any final comments you wanted to make, Dr. Goldberg?
It's a new situation with a lot of uncertainty. You know that you are making mistakes, but you have to, you have to maybe to feel that you are in some kind of a control. There are a lot of good things that happened in this period of time, a lot of solidarity, a lot of working together. And the country and the citizens, together with us, the health staff, are going to win this coronavirus. I hope soon. Thank you, Andrew.
Thank you. Thank you. Thank you, Sarah. Well, that concludes today's webinar. We have one coming up in about 2 weeks' time on triage and ethics related to COVID-19. We'll include that information in the email that goes out with a link to the slide deck from today and the audio recording. So thank you, everybody.
Thank you.